So why don't we go ahead and move to Dr. Schneider, and he's going to keep going down the aorta. And now we're going to deal with some infrarenal issues that become some iliac issues.
Okay, let me see if I can share my screen here. Can you see that?
We can.
Excellent. So I do have some conflicts of interest there. But in any event, this is we're marching down the aorta, and I'm going to talk more about infrarenal EVAR and iliac issues with the iliac branch devices. This is a 65-year-old man who had an EVAR elsewhere just a couple of years ago in 2018 who was referred to us. And he was referred because on routine surveillance imaging was noted that he had pretty severe kinking of both iliac limbs and dilation of both of the common iliac arteries subsequent to his EVAR. He didn't have an obvious endoleak. The aortic aneurysm hadn't grown, but there was some concern about the appearance, and I'll show you that. He had COPD, hypertension, was on same medications that a lot of our patients are, and he's an active smoker. So this is his CT scan. Here you can see this was a Zenith device. There's a little thrombus within it, but here's the aneurysm. No real endoleak, but you can start to see that something's amiss with that left iliac limb. And both of these common iliac arteries are a little bit dilated. I think this will run back the opposite direction, so you kind of look at that again. So some enlargement of the bilateral common iliac arteries. This left limb is barely into the left common iliac artery now, and then there's some kinking, which I'll show you on some other images. So here's a coronal shot. Again, you can see this left iliac limb that is kinked. There's also kinking of the right limb, and the left iliac limb has retracted and is almost back in the aneurysm sac.
It looks like both of them have potentially migrated north.
Yeah, I think so. And so here you can see in the 3D reconstruction and some other reconstructions, measuring the iliac arteries on the right, it was about 26 millimeters on both sides now. These were 24 millimeter Zenith limbs that were put in there. And then looking at the aneurysm again, the AAA had been stable. There was no obvious endoleak there. So here's our first question, what to do with this patient.
Hey Darren, were those 20 millimeter Zenith limbs the old style? Like, was it an old like 10 years ago Zenith, or was it spiral Z limbs that are more flexible?
No, they're spiral Zs, but I think they were 24 millimeter diameter, and so that should give you some concern too, because the iliacs are now measuring 26.
Yep.
And I think a good point here is, treating common iliac artery aneurysms, which is really what they were, and especially when they're short, it's not going to work. I mean, the durability of this device was what, a year and a half, 2 years. That's, ideally we're not looking for that. We're looking for more long-term treatment. And this is the type of patient that, done somewhere where there's no follow-up, the next time they follow up, it's going to be with a rupture.
Yeah, and so looks like a lot of people want to do revision with an iliac branch device, but I think you're spot on, Ed. This is a guy who's not that old. He's 65 years old. Probably could have had an open repair even initially. And he's likely to live a long time, right? 10, 20 years. And so clearly this hasn't been durable in like a year and a half or 2 years. They haven't treated all his aneurysmal disease. And so he needs a solution that's going to provide him some durability. So I think that just deciding to follow him because he doesn't have an endoleak and a stable AAA and he's asymptomatic is the wrong answer, because I do think this is someone who's at risk, impending risk potentially, to come back with a rupture, like Ed said.
And I think the other big
value now. Yes, sir. Is there much value now for these large flared limbs? There's 28. I mean, is there a good time to use them with the iliac branch device now? I feel like there's like bound to fail unless somebody's like it's much older, won't tolerate a long procedure. I mean, is there a good use for them now?
Yeah, well, I totally agree. I mean, I think that's basically sealing in an aneurysm. We now have devices where you can preserve the hypogastric artery and not seal in an aneurysm and get a more durable reconstruction. So I think that's important. I think there is a role for them, but I think it's limited. And so not in a 65-year-old, but if I had somebody who was 85, who had a large AAA and kind of an ectatic iliac that was around 2 centimeters, I'm not going to put an iliac branch in that guy. I'm just going to put in a flared limb and get him off the table, because that's likely to be all he needs.
And Saher, that's a great point, right? There's a fair amount of data now suggesting that with the proximal aortic neck, if we're going into something greater than 30 or 32, there's going to be aortic neck dilatation over time. And so there's really no good reason to land a 28 device in an iliac artery. I mean, do something, right? You can do an extra-anatomic bypass, or you can, debranch it. You can do, the branch device. You can do a parallel graft. There's so many options that it just doesn't make sense to put a 28 in an iliac.
So we have a question from the audience: is how are you going to get an iliac branch through all that kinked metal? And that was a question I was going to ask: is how concerned are the panelists of trying to push something through there? Because the risk is when you bring an iliac branch device, you end up with a limb occlusion.
Yeah.
So I was just going to say, whenever when they retract up, once you get that stiff wire in, and typically a lot of times we'll do it through and through. Oftentimes they'll just straighten right up.
Yeah,
I was going to say that this one wasn't that easy.
Through and through access will help a great deal, I guess.
Yeah. So I agree. I think that's a concern, and that played into our strategy for what we did here. So let me show you. One thing we did is I decided to coil and cover the left side, and I know that I'm this big hypogastric artery preservation guy, but now I'm dealing with a device that's got kink limbs on both sides. And the other thing I didn't show you was that this hypogastric on the left had about a 95% stenosis. It was barely even patent. So in that case, he had no symptoms from that. I didn't think that he really needed that left hypogastric then, but it made it important for me to preserve the right side. So the strategy we were going to use was to coil and cover the left, reinforce and straighten that limb. So this was extended using an excluder limb. And then we used some additional, I think I got an additional ICAST in there to reinforce it and really straighten out that kink limb, because despite the devices and the stiff wire, it didn't entirely straighten on its own. So it needed a little additional persuasion.
That's been my mantra as well, is that if I'm going to reline through there, I'm going to put some balloon expandable metal in through whatever stent graft I line it down through, because I've had them kink and occlude, and so I want that plastered there.
And so now,
are you guys worried? How often would you guys cover both hypogastrics in a setting like this? Would you ever?
I would try very hard not to sacrifice both.
Yeah, much older patient that might still be leaking retrograde. Yeah, I guess you could stage, maybe 2 weeks apart, just out of some belief that maybe staging it could help. But yeah, but in this patient, 65 or whatever, I think you have to keep one. You have to keep one going.
Yeah, I think this guy's 65. He actually still works. He's got aneurysmal disease at a fairly young age. He's still smoking. He might have additional aneurysmal degeneration proximally. And then you're going to get into issues with potential spinal cord ischemia if you don't preserve this at least some hypogastric perfusion. So I think it is important to try to preserve it. And this is a circumstance that you run into not just because he's got a kink limb, but also in somebody who comes back with an actual type 1B endo leak, and you're going to revise an EVAR device with an iliac branch device. So I thought it might be nice to go through that a little bit more. So that comes to the second question. So I'm going to put an iliac branch device. We're going to use an IBE device on the right side. And when you're doing that, how are you going to access that hypogastric artery to put that branch into the hypogastric artery?
And I think this is one of those things where, as technology has changed, our options have grown, because it's very different today than it was 2 years ago and even 4 years ago. And I've seen a lot of unique approaches to this, with people using the OSCOR sheath from the ipsilateral side or the contralateral side. But I'd probably come from the arm with a VBX and just call it a day and make it easy. And now that the VBX is, you can get the 8 large and take it up to any diameter, and it's 135 shaft. You can usually get it through an upper axillary brachial incision.
Yeah, so I've gone to even with these type 1B endoleaks and revising EVAR limbs. So it's interesting, there's no consensus here, right? People come ipsilateral, contralateral, brachial, axillary artery, you know, all bets are off, dealer's choice. I typically do these, like I did this case under local and sedation with percutaneous femoral access. And so for that reason, I try to stay away from axillary and brachial approaches if I can. With revising prior EVAR devices, you can actually easily come around the bifurcation of those devices. Gustavo Oderich has published a technique utilizing a dry seal sheath that you can support with a sheath from the contralateral side. And like you said, you can also use the tour guide or OSCOR devices and even do it from an ipsilateral approach. I typically would do this from a contralateral femoral approach, but in this case, I'd already had to straighten out that limb, reline it with an additional balloon expandable stent. I really wasn't keen on trying to drive something around the existing EVAR bifurcation. So I decided to do this from a ipsilateral femoral artery approach. And I'll show you a little trick that I have kind of learned with the IBE device to make that even easier, utilizing the preloaded catheter through the internal iliac limb. So what we do is, you can see on the right side here, we've actually put a 16 French sheath up from the right groin into the aorta. And then once we've done that, on the left panel, you can see I've taken just a regular glide wire and I've looped it and I've kind of loaded it into another little sheath so I can load that up, the loop, into the dry seal sheath and just push that loop of the looped wire up into the aorta. And then, so here you can see here, there's the loop being sent up into the aorta, and I've still got the two ends of that wire coming out the back of the dry seal. And then that's what I'm going to load the IBE device onto. So I'm going to load, this is one single wire that goes up, loops around, comes back out. I'm going to load one end of that wire onto the central lumen, and the other end of that wire I put through the preloaded internal iliac limb so that I can take advantage of that preloaded limb and do this all from an ipsilateral approach. And so then we push that up in the sheath, pull the sheath back, do our angiography through the sheath to orient the device. And then again, what we've got is, instead of that standard through wire from the contralateral side that we've loaded the device over, I've loaded this over this through wire, this looped wire from an ipsilateral approach. And then we'll go ahead and deploy the device once we're happy with the position. And then just pull this loop wire back until it's seated on the bifurcation of the IDE. And then I actually then introduce an OSCOR sheath over that through wire. It really helps hold it in position. And you can keep that sheath in place even while delivering the VBX. And so that you have complete pushability, and it's easy to push the device around that turn and make that turn. So we got that device in place, put a wire well out, usually into posterior division or gluteal branch. We still have that looped through wire in place, holding this OSCOR in stable position. And then the VBX is really a game changer. It's such a flexible deliverable device, even though it's balloon expandable. And once we had the VBX in device, that's when I pulled back that through wire so I could then deploy the VBX.
What size OSCOR sheath were you using there, Darren?
I believe this was an 8.5 French. And this is an 8L that we put in.
So then, would anybody ever try and do this person and convert him to an open surgery, young, healthy patient? I mean, I would say, you know, here at the clinic, these are sometimes I'll convert someone to open surgery and not do all this endo stuff, but this is clearly a really cool way to use the OSCOR sheath. I got to say that, you know, you see something and think, I can't wait till I get to try that one.
Yep. I've got one that I'm ready to do, so I'm going to have to borrow these slides, Darren. I just was thinking about how to do it.
Yeah. So it actually works pretty well. I mean, my logic, I mean, you could say the guy's young and you should consider an open surgical repair, but I think the reality is if you take this repair into healthy vessels down in the external iliacs bilaterally, and those are non-aneurysmal, that I think is going to provide him with a durable result. You can always come back later and do an open conversion. It's not like you're putting all these snorkels into the visceral vessels. I mean, you still could convert this if you ever had to.
Sean, to kind of answer your question, I had a patient exactly like this, right? Prior EVAR, bilateral commons, I coil embolized one side, took it down, and then instead of doing this with an IBE, I did a retroperitoneal incision and did an external to internal iliac artery bypass and then extended down. And the reason I did that was because there was a lot of tortuosity in that internal iliac artery, and I was concerned about long-term durability of a stent in place. So, there's kind of the in-between, without totally explanting the whole EVAR device and, doing some combined open endo approach.
So I want to make sure the attendees get something here, but I think that one of the key points we talked about is the limbs and how kinked they were. And I think one of the important parts is he's got, basically a catheter on one side, a floppy wire on the other side. So he's going to let these devices lay in their normal position because we don't want it to be straightening out a kink with stiff wires when you're taking your completion pictures. And then you come out and, post-op day 2, they thrombose. And we've all lived through that learning curve. And I think that, sometimes people forget that step. And, to me, that's always the most important thing is look how nice and straight they are with at the end result here, which is awesome.
I think that's a really important point, Sean. And so every time I do this, particularly when you extend down into the external iliacs or in tortuous anatomy, I always remove the stiff wire. So this is just a floppy glide wire on the right side. And you can see I pulled my sheath all the way back down to just above the inguinal ligament. And the same thing on the other side, the sheath pulled back and just the pigtail catheter there to do my completion. So there's no stiff sheaths or wires distorting the anatomy. This is what it's going to look like. This is where it's going to live, and then you can make sure it's okay.
So that's some amazing cases. Any last final thoughts in this case?
Love the loop technique. That's brilliant.
I should draw up some pictures of that, or tell the Mayo Clinic to draw some nice pictures of it.
I know. I showed it to Gustavo already, so he's probably got his artist and
he already wrote it.
A fellow writing it up already. So.